Nick Majerison here. Welcome to Top Med Talk. Make sure you listen to the end of this podcast where we have a special announcement about how you can have the entire Top Med Talk back catalogue for free. Before that though, today's Top Med Talk is ASA 2018 San Francisco, the Smith's Medical Symposium on Enhanced Recovery. Recorded before a live audience, this Q&A session was at the meeting of the American Society of Anesthesiologists, the ASA, at a specially hosted dinner where those in attendance and the online audience could submit questions. This is part 4 of 6. In this piece, Desiree Chappell interviews her guest, Dr. Elizabeth Chereau, Vice President of Medical Affairs at AXA Women's Health, with contributions from Monty Mython, Top Med Talk Editor-in-Chief and Smith's Medical Professor of Anaesthesia and Critical Care at University College, London.
Top Med Talk.
All right. Welcome back to Top Med Talk Live here at the Smith's Medical Education Symposium at the W Hotel during Anesthesiology 2018 here in beautiful San Francisco, California. Thank you guys so much for joining us. I'm Desiree Chappell, anchor for Top Med Talk, and I'm joined by the host for the evening, my friend, my partner, Monty Mython, Editor-in-Chief of Top Med Talk. Hello, Monty.
Hey, Desiree, great to be back.
I'm glad you're here. So we were so privileged to sit down with Dr. Vincent Chan. Thank you, Dr. Chan, for talking to us a little bit about regional anesthesia and enhanced recovery. I think we had some great questions during the session. Now, we want to make sure that everyone here and everyone at home is utilizing the Slido technology. So did everybody pull their phone out and log in? That's great. Yes, I see that lots of the questions are adding up here. I wanted to now really introduce our next very special guest and a friend of mine now, which I'm so excited to introduce, is Dr. Elizabeth Chereau. Come on up, Elizabeth. Let's go. How are you? I'm going to give you a big hug. All right. Thank you so much for joining us. Dr. Chereau, may I call you Elizabeth? Please. Okay, great. Thanks. She is an obstetrician, so she's in an anesthesia meeting. And she is not an anesthesiologist, so go easy on her.
Ouch.
Let's not.
I feel like the ether screen should be right here.
That's for sure. So, Elizabeth, you are the Vice President of Medical Affairs for AXA, which is an organization. It's actually the largest OB/GYN practice in New Jersey and Pennsylvania, correct?
Yeah, it's actually the largest in the country.
The largest in the country?
Yeah, we have about 270 providers. Wow. So, yeah, I know everybody just paused due to this awe in the audience. Yeah, so we merged into a whole bunch of care centers on both sides. A whole bunch of private practices came together in 2016.
Yeah, so that and it all works, right? Perfectly?
Whatever works perfectly.
Yes.
But yes, and starting in this spring, I became the Vice President of Medical Affairs.
All right. So we met because you became involved with the evidence-based perioperative medicine group here in the U.S. and started talking to us and with us about enhanced recovery for the elective C-section patient.
Yeah, so that was a great conversation we had down in North Carolina.
Yeah.
We started in 2016, about the same time I guess I merged. That's interesting. I partnered with the anesthesiologist chairman at my hospital. We started doing enhanced recovery for women who are having repeat cesarean sections. We've done probably in the first year, we hit our target of about 100 patients and have been now launching with both scheduled repeat cesarean sections and sections for women who are in labor.
Cool. All right. Well, we are going to go ahead and start the Slido questions and get rolling through those. If anybody, like Monty said before, if anybody in the audience wants to answer a question, please raise your hand up high and have the wonderful Joff Lacey.
I see the first question. The first question's a hot question.
Let's see.
So what's the length of stay?
Yeah, that's my question.
Okay, I'll be quiet. So my institution, the standard length of stay was 3.7 days. When we first launched our enhanced recovery, we watched in the average length of stay going to 2.4. We have it down to 2.1, which I just looked at yesterday. So yeah, we have patients going. I have a lot of patients who go home on day one as well. But yeah, that we quickly reduced
For
length of
elective
stay.
C-sections,
For
they go home on
elective
day one.
C-sections, they go home on day one. In the United States, and I say that because Monty's here, there's the Marquette Law, right? So we tried a long time ago to drive-by surgeries were not a good idea, right? So, which is what this felt like at first, which was a huge barrier for a lot of obstetricians to think about. But the Marquette Law allows payers to pay for 4 days in the hospital. So a woman is guaranteed 4 days to stay by her insurance company by a federal law. A little barrier to get this started.
Yeah, absolutely. So we're just going to dive right in here.
And I'm not going to read them over your shoulder.
I am.
My glasses don't work that well.
So this is my question, but Monty typed it in for me. So there's different. There's the language.
I didn't get to see these ahead of time.
Yeah,
okay, go ahead.
Do moms or moms?
Moms, right? Depending where you are. Yes.
Do they want to go home in a day?
So
I
fascinating.
don't know if I did.
So I recently, third baby, wanted to move, wanted to eat. Why not go home? Certainly, you might say, why go home if you're the mom with 2 other kids at home, right? Are you going to send me home with a babysitter and a lactation consultant? Then maybe I would definitely go home. But for the right patient, day one is appropriate. And we aren't having patients bounce back to the hospital. In fact, we're actually following them on a dashboard. As you know, I've talked about this before at BOM. We launched an app starting at 36 weeks for patients to download. It gives them all the patient information about what their C-section is going to be like, what their postoperative care expectations are, which, as you know, if you engage a patient and let them join in the process, usually become your partner in decreasing their opioid use, mobilizing, eating, all the things that Monty just talked about earlier. We had patients say, wow, I meet all this criteria. Why wouldn't I want to go home? There are the occasional patient that I start chuckling at who definitely likes the food better in the hospital than at home, but we really have decreased our length of stay. It's kind of impressive.
And the moms ask. I mean, that was one
thing.
They do. Yeah.
They ask, so they're downloading that information at 36 weeks. So their expectation is they're not going to stay all 4 days.
Yeah.
And most of them by day 2 are, let me get me out of here. I'm sort of tired of the lady cleaning up the floors, and I'm walking, I'm peeing, I'm eating. I'm in good pain control. And then from our standpoint, with our app, we have a dashboard that we can log in and look at them every day. And so my nurses are doing that in my office and watching my patient, looking at her mood scores, looking at her breastfeeding.
You have take mood scores?
We do. So we use a couple more elements than Monty does. So it's not just about eating and mobilization and pain, but we actually look at mood, because as you can tell, postpartum depression is a huge, my world is that. Yeah. And the American College of OBGYN, hoping there's no obstetricians here, are talking about the 4th trimester as following these women, not just 6 weeks out, but actually 6 months out. But American College of OBGYN hasn't given me any tools to do that with. Yeah. So we launched a dashboard for patients to interactively talk to us. And so we look at it. They like to fill out information. Patients, my millennials, are filling out way too much information. Yeah. I'll leave it at that. But it's been a great tool for us to use and to engage them early before their procedure. But we've had, I was just discussing this at the table, 98% engagement rate, and through that 3 week, for that postoperative time period, it really doesn't drop below 75%. So
that's impressive.
It's been fun.
Yeah.
It's been fun, and it's patient-driven data, which we all can say data is now the big thing.
King.
So
yeah, cool. All right. So the next question again from me, and if you guys have, please vote.
That's right. What about my wine up? If I knew they were all from you, okay.
We can sit and talk about this all day long, but I know there are a lot of questions out there in the audience that people have talked to me about wanting to know more about enhanced recovery for C-section. So vote those questions up. The next one is: don't C-section patients? Are they already? Didn't you already do a lot of the enhanced recovery principles? It wasn't like your moms were drinking, eating, and moving after surgery, right?
So we certainly let them eat right away, but we do I would tell you that the dogma around where I work is that they are starved for 6 hours because they're pregnant. And so they're emptying times. We absolutely do a carbohydrate drink. It's now stocked on labor room. So that was all new. We warm people in the operating room, warm fluids. That was new. Mobilizing patients, they kept their fully in for 24 hours. We take them out at 6 hours. I was sort of shocked the first time I saw a patient at going down the hallway as I was going to round on her the first morning, and she was walking the hall. She looked better than I did after being up for 24 hours. So, well, that's not saying much these days. But as I've gotten older doing call, it's harder. But she was doing phenomenal. So we did parts of it. And Monty sort of said, if you're doing this, you're doing ERAS. The only other part of this is patient engagement, and I think that's huge. It's expectations about what your pain is going to be like, what your mobilization is going to be like. So, and I'll tell you, across our patients from all cultural backgrounds, which are very different going into surgery, we really have had fabulous outcomes. So yes, we did a little bit of ERAS, but I would say the smidge edge, and I would say we were doing probably 60%. We're now doing 90 plus.
Wow, that's impressive. And then bringing it all together is the synergistic effect
absolutely.
of all of that. Yeah. So what is the role of tap blocks for C-section patients in most enhanced recovery protocols? Do you use tap blocks?
So excellent question. We actually are... my anesthesiologist, Dr. Kett, who I should give a shout out because he might be listening.
That's
and
right.
I should secretly say something about my husband who's up on the East Coast, hopefully listening, because he's taking care of my kids this weekend. But I got that, snuck that in. Yes. I got my points. But Dr. Kett and I started one of the controlled trials with Duke, with the Brigham, with tap blocks after the C-section is completed with long-acting bupivacaine versus short-acting bupivacaine. That data isn't out yet, but I can secretly say that, yes, we had better pain scores and decrease of opioid use. I, however, because Dr. Kett and I, my anesthesiologist, kind of go back and forth on this, started doing long blocks right in the incision at the time of closure.
So more of the field block.
Exactly. So not tap, but right at closure. There was a really good article that came out in the Green Journal, which is our journal of obstetrics and gynecology, about doing long-acting Exparel with short-acting mixed with some saline at the time of closure. And they looked at mobilization, which I found funny because I found opioid use to be a better indicator of kind of what my goal was. And we had an 86% reduction in opioids. So about 60% of our patients go home with no opioid prescription. So there was a question about whether that was a good thing, bad thing. I mean, I do think the pendulum could swing all the way to, I don't want these patients going home and being miserable. Yes, my dashboard works great for that. But it's also about, okay, can I give you the prescription and can you return it to me if you don't fill it? Or even better is, if you fill your prescription, bring me back the ones you don't use. Because that is the diversion, right? That's the script that's sitting out there. That's the opioid crisis that I'm used to, or that I know, because it's really, those are the patients that get addicted because it's sitting there, and it's not usually the people who are getting addicted. It's not the patient I just exposed for the first time to opioids. It's her sister, her brother, her cousin with a back injury that's using it because it's sitting on the shelf. So that diversion.
Or the plumber. That comes in and steals it from the house. It happens. Right.
No, it happens. And so it's absolutely, in New Jersey, our average prescription was 40. Oxycodone. That's huge. And so now in our institution, we're down to 20. I would tell you my particular care center, 60% are using none. And we've had great success. And our patient satisfaction has stayed the same. We've really looked at pain scores as well.
Cool. All right. Well, moving on so we can get through our Cyto questions. Tell us your hospital's protocol for enhanced recovery for mom.
So, mom, at 36 weeks, downloads her app. At 39, the day before surgery, comes in, gets her blood drawn, picks up Pepsid, picks up a carbohydrate load. I'm not going to push whichever drink. Let's just leave it at carbohydrate and electrolyte drink. She'll drink that the night before and take her Pepsid. She'll drink it 2 hours before her surgery with another dose of Pepsid in the morning. She'll then get a standardized anti-nausea when she goes into the operating room. She'll have a warmer, she'll have warm fluids. We cap the fluid after a certain amount, as long as there wasn't a lot of blood loss. In the recovery, C-section is done like a standard C-section. For us, baby goes on the chest. We also do delayed cord clamping. And encouraging mom to breastfeed as much as possible. So we also have that ether screen is not blue, it's clear, so they get to watch me, which is weird but fun at the same time. It feels like Baby in the Bubble kind of thing, but from the other side of the table. But babies, right? So we encourage moms to breastfeed in the operating room. We try and restrict the IV, so we're really we don't strap them down. They're really mobilized. So it's Decadron, Zofran. I'm trying to think if there's something else. Then we give Toradol and Ofirmab starting in the recovery room. We switch over to PO Tylenol. I'm trying to speak fast. We keep 24 hours of Toradol on board and switch to PO Tylenol. In the recovery room, mom is breastfeeding. Mom is encouraged to chew gum, drink, all those fun things, which really getting the nursing staff encouraged for all this has been, once it starts working, they all want to do it. Yeah. On the floor, mom gets her catheter out in 6 hours, eats every meal at the table, is encouraged to eat solid food right away. Trying to think what else do we do that's different. That's about it. I think that's it. That's mom's experience. Did I do okay? That's ERAS in 30 seconds by Dr. Sharon.
Yeah, no doubt. You need to record that.
I do.
As that was the mum perspective, and one of the things we were hearing earlier on today is some of the delay in discharge are actually baby-related issues.
Yeah.
Yes. So it can be,
nursing.
Absolutely. It can be a whole bunch of things, right? And can be anything from babies in the NICU for transition. Baby could have bilirubin, that kind of thing. But nowadays, the pediatricians definitely had to be on board with this. This was not something that when we introduced, we started with grand rounds with the pediatricians. We actually sat down and went to their business meeting. We then asked them all for feedback. We had long conversations about that too. Not that it was we wanted to kick them out. We wanted them comfortable with the idea that they would have to come back to the office just like they do for vaginal delivery, right? Vaginal deliveries leave in 2 days. But you're right. A few of the patients that stay longer are usually NICU issues. And those are more laboring patients than they are the scheduled.
In the UK, we have what are called community midwives. If people have watched the BBC programme The Midwife, they're real. They don't tend to ride bicycles anymore, but they do come straight round. If you get people home quickly, they do come straight round to the house to check everything out, help to get the baby on the breast, make a cup of tea, make sure everything's okay domestically.
Right. We have doulas. We have doulas in this country, but you have to pay for that. That's cash service. There's not a lot of visiting nurse services, is what you're really describing, except for in a prettier setting, for postpartum care. Absolutely, they don't have it. But they have lactation consultants who certainly by phone that kind of thing. But they don't do a lot of visiting nurse service for. But it's the next layer
Wouldn't that be cool to add to enhanced recovery?
And actually have talked to a payer who is very interested in thinking about adding on the lactation consultant, the doula, the postpartum nurse to be able to do that.
Top Med Talk.
I mentioned at the start our back catalogue of over 300 podcasts. You can download all of these completely free today. Top Med Talk is committed to open source publishing and will remain so for all new material. As we continue to grow beyond our expectations in subscribers and engagement of thought leaders around the world, we will be diligently working to enhance the experience of our listeners by creating a back catalogue, a highly curated collection of our podcasts, advanced search options and special bonus features. This will be available through our new app at a fee. So we encourage you to download all of the podcasts right now. It's completely free through to the end of this month and contains some absolute classics from some of the greats. Enjoy.